How's it going, everybody? Welcome to today's episode of the ACR RadExam. My name is Shay Laporte, and I'm a PGY3 integrated IR resident at UAB Hospital in Birmingham, Alabama. Today we're going to be discussing a chest trauma case. So the history of this patient was a 61-year-old male with decompensated cirrhosis and glottic squamous cell carcinoma, which he had already had surgically resected and received adjuvant radiation. He presented to our trauma bay following a self-inflicted GSW to his left hemithorax. On primary trauma survey, he had ballistic sites on his left anterior and posterior chest. He was hypotensive to 60 over palp. He was subsequently resuscitated with 4 units of whole blood. He also had diminished breath sounds on his left side, for which he received a left-sided chest tube, and then he was subsequently intubated for respiratory distress. Per our trauma services standard imaging protocol, this patient received a single-phase CT chest with IV contrast, which demonstrated multiple hyperdense foci in the left hilar region, which are indicated by these yellow arrows. These findings were concerning for active extravasation versus pulmonary artery pseudoaneurysms, which we were unable to differentiate between the two on a single-phase exam. The patient subsequently underwent a triple-phase CT for further evaluation. As you can see in the left hilar region on both the arterial and venous phases, indicated by the yellow arrows, there are hyperdense foci again appreciated. I think you can see here that on the arterial and venous phases, those hyperdense foci look very similar to each other, which sways us in the direction that these are probably pulmonary artery pseudoaneurysms, as we would expect active extravasation to enlarge between the arterial and venous phases. However, they have a very similar appearance, so we were pretty confident that these were pulmonary artery pseudoaneurysms. So our first question for today's video, what would be the treatment of a pulmonary artery pseudoaneurysm in this case? And I'll give you a few seconds to think about that. If you chose embolization, give yourself a pat on the back because that is correct. So before we dive into the actual case itself, I'd like to give a little bit of background on pulmonary artery pseudoaneurysms. Listed here below, we have several of the causes in order of frequency of these pulmonary artery pseudoaneurysms, with the most common being infectious. And those can range from septic emboli causing mycotic aneurysms to necrotizing pneumonia causing parenchymal and vessel destruction. Thoracic tumors can cause them. We can cause them iatrogenically with Swan-Ganz catheter placements, and in the case of our patient, trauma. The symptoms that these patients experience have a wide range, from anywhere from asymptomatic all the way to hemorrhagic shock like our patient had. And in between those ranges, dyspnea and hemoptysis can also occur, not infrequently. As we discussed in the first question, the first-line treatment is endovascular embolization, with the possible embolic agents having a wide range. The most common is probably coils, but that's not to say that plugs, glue, Lipiodol, covered stents, and non-adhesive embolic agents don't have their place in treatment of pulmonary artery pseudoaneurysms. One thing to keep in mind when you're doing your initial angiography of a pulmonary artery pseudoaneurysm, if there is concern that there might be an arteriovenous fistula or malformation, most clinicians would agree that it's probably best not to use small particles to embolize, as those could get thrown into the venous system and subsequently back into the systemic circulation and cause stroke-like symptoms. And now to discuss our actual angiography case. As you can see here in this video, we have a 5 French diagnostic catheter parked in the left pulmonary artery. After contrast administration, you can see swirling inside of a large pseudoaneurysm in the left mid-lung, which we then chose to proceed with coil embolization, as seen on the next slide. Here is a still radiograph following deployment of our endovascular coils, which we deployed inside the actual pseudoaneurysm sac itself. And this is to form a nidus for clot and thrombus to form inside the pseudoaneurysm sac, which will decrease the risk of rupture and subsequent complication. And subsequently, we did a final run with our 5 French flush catheter, which demonstrated that we had achieved satisfactory occlusion of this pulmonary pseudoaneurysm. This patient ended up doing really well and was discharged from the hospital subsequently within a week or so. So in conclusion, trauma is a common cause of pulmonary artery pseudoaneurysm. Endovascular embolization is the first-line treatment for these pseudoaneurysms, and coil embolization is the most commonly used embolic. However, it is important to remember that numerous viable options do exist, and it will often vary from user to user. And that's all we have for you guys. Here are our resources if you'd like to check them out. We'll see you next time.